One that really shocks me, really shocks me. We did a clinical guideline on people who self-harm, people who hurt themselves. Every single patient that we talked to said that when they hurt themselves, when they went to the emergency department, nobody ever offered them anesthesia to suture their wounds. They were never offered pain relief because they were always told, well, it didn't hurt when you cut yourself, so why would you want pain relief now? Now, from just a human rights and a kind of humanity point of view, this just seems so wrong. But again, there was nothing in the research literature to indicate that this was a problem. And so by talking to patients, we were able to say pretty much the first recommendation in the guideline: if a patient presents at the emergency department having harmed themselves, offer them anesthesia. And so we were able to come up with an entirely legitimate and not expensive recommendation that would hugely alter the quality of these people's lives and the quality of their interactions with health professionals. And of course, what this reveals as well is need for training and sensitivity of emergency department staff and that interaction between emergency department staff and mental health professionals, and how there isn't necessarily the same kind of training being offered. And this one was pretty shocking too, given the picture, and I'm sorry about the picture, but I think it's really important. We were looking at high-dose rate brachytherapy for cervical carcinoma, an internal radiation for cervical carcinoma. The women who had had this procedure told us it was distressing and undignified, and it was painful. Well, I mean, looking at that, it's self-evident that it was painful. But again, nothing in the research evidence indicated that pain or dignity or distress was an issue for women undergoing this procedure. And so what we were able to do, again, is come up with some explicit recommendations that anyone having this procedure should be offered adequate pain relief and should be given counselling about the potential distress involved in having the procedure. So I hope those case studies give you an indication of where I think that patients do actually have an impact on what we do and are able to either challenge the evidence base, add to it, or give the opportunity for their values and preferences to be exercised. I now want to talk about some of the difficulties, because it's not perfect. I'd like to say it was. I'd like to say that all patients are beautifully behaved and all health professionals treat them really well, and there's never any tension, but it's not always like that. It's really important that you get the right people. What I'm going to do now is list what the problems are, and then I'm going to talk about how you kind of resolve some of those problems. It's really important, as I said before, that you don't get someone who has a very particular bad experience they want to relive over and over again, and that all they want from the guidance is for that bad experience never to happen again. It's a completely legitimate position to make, but we need people who can approach evidence objectively and bring their experience to bear on that. We have a number of problems with the attitudes of some health professionals and some academics. We have problems with the language that they use, their attitude towards having a patient on the group, their attitudes to the fact that they talk about the disease in complete isolation from the patient as if it's just cancer somewhere, not attached to a person in any way. We have a real problem in managing expectations. People come to these groups with very different expectations, and it's part of our team's role to try and restrain some of those. People are never happy with the scope, ever. And that's not just patients. Nobody's ever happy with the scope. They always want more stuff to go in. They always want more populations to go in, or for it to cover different topics. But because we're very restricted by time and by resources, we have to keep the scopes relatively tight. But we have this weird procedural thing where the people who develop the guidance aren't the people necessarily who develop the scope. And so the first couple of meetings, there'll be this kind of, but I think it should be this, and I think it should be that. And so that's something we're reviewing our scope processes at the moment to make sure that we can try and get that process a bit more integrated. There is a huge issue about evidence from patients. There is a huge issue about the fact that there's sometimes not very much of it. But equally, there's an issue that a lot of our researchers don't know what to do with it when they find it, even if they do find it. They are trained in doing meta-analysis of randomized controlled trials, and you ask them to analyze a piece of qualitative data, and they just don't know what to do with it. They think that evidence from patients is at the bottom of the so-called hierarchy of evidence, whereas I would argue very strongly that evidence from patients and qualitative information sits alongside quantitative data and provides you with that context. There are lots of issues about the groups being well integrated. The professionals sit here, the patients sit here, and they don't talk to each other. That's sometimes a problem. The professionals all know each other because it's usually quite a specialist area, so they're all hanging out and being friends, and then the patients are sitting over here, and they're not always very well integrated into the group. There is an issue about so-called professional patients, patients whose job it is to sit on committees like this, and they can bring something useful, but actually we want something fresher than that sometimes. And there is a big issue about the groups that aren't represented at the table. So we've got children, we've got people with learning disabilities, we've got people who have sensory disabilities. Because of the nature of the work, it can be very difficult to make sure that their perspectives are included, and that we don't take the people who care for them as proxies for their own views. Carers have a very important contribution to make, and parents have a very important contribution to make from a parent or a carer perspective, but they can't speak for their children, or they can't speak for the person that they're looking after. It's not appropriate to assume that the same issues are there for both groups. And this perennial issue of language and jargon, making sure that the language used is respectful and that all jargon is explained wherever possible. So trying to resolve these difficulties, we try and be really, really explicit on the recruitment materials that we use and our expectations in terms of the conduct of both the lay people and the health professionals. So that can try and address some of these issues about having the right people on board. As far as the attitudes of health professionals and academics, we find that we try and offer as much training as we can from a patient perspective. And we find often that describing those kind of case studies that I referred to earlier, describing the positive impact and the added value, is the thing that can actually really turn those attitudes around. In terms of managing people's expectations, a key part of my team's job is to make sure that we really, really prepare people before the group work starts, so that they have a much clearer idea about the amount of work involved and the nature of the work. And so we will always have a significant amount of contact with people before they even go to their first meeting. As part of that, we also have to be really clear with them about what it is that the guideline can and cannot cover. And so we have to make sure that people know that once they've signed up to this group, the scope is the framework that they're working to. We try and promote wherever possible the use of good quality patient data and rigorous qualitative data wherever it is. And I can't recommend highly enough an organisation in the UK called Health Talk Online. It used to be called DIPEX, the Database of Individual Patient Experience. It's based at the University of Oxford, and it is a number of modules by topic where they have interviewed up to 50, 60 patients with a particular condition using rigorous qualitative techniques to saturation point, to the point where they're getting no new information about particular conditions. And this information is available on the website as audio, video, or written transcripts. And it's an enormously helpful piece of work. And if we're lucky, the guidance we get to work on has a module that matches, but it doesn't always work. But we try to make sure that if there is information such as the work here, that it does get incorporated into the guideline. What we've found from doing some analysis is that in terms of integrating the groups, there are some formal things that you can do. There are formal things around training together and things like that. But actually, the thing that makes the greatest difference is all the informal stuff. It's the conversations over coffee. It's having lunch together. It's maybe going out for a meal after your first meeting. These kind of things can't be underestimated in bringing a group together and to making sure that the patients feel integrated. Excuse me. In order to make sure that we don't keep recruiting the same professional patients to each group, we recruit afresh each time, and we don't just call our friends and say, you were on this other group, do you want to be on this one? Tempting though that is sometimes when you get really, really good people. We can always find other work for them to do though. So we recruit afresh for every new topic. And one of the things that we are working on and need to do more work on is about establishing some formal mechanisms for engaging with the groups that aren't at the table. And that's a project for the future, but it is something that we really need to resolve, because as we get more and more children's topics, for example, to work on, we scratch our heads anew each time about how we will make sure that children are involved. And finally, this issue about language and jargon. We really encourage our lay members, and actually any member of the group, to be unafraid to raise unacceptable or unclear terminology. It's sometimes very shocking, the derogatory language that health professionals use about patients, even when they're sitting next to them, which I find very strange. But we, as part of what we do to try and prepare people for the group, is to encourage them not to be afraid to say, I find that language difficult, I find that language unacceptable, or actually, I just don't understand a particular piece of research terminology, and can you explain it to me, please? As I said before, we're increasingly seeing people enthusiastic about supporting implementation, and there's a role for both organisations and individuals. And this support ranges hugely in terms of some very low-level activities, such as promoting a piece of guidance on a website or producing a leaflet, through to some of the very large organisations who have funded nurse specialist posts in the health service as a consequence of the guidance that we've produced. These are very rich organisations, but nevertheless, they've provided something like 3 years' worth of funding for specialist nurse posts as a direct consequence of our recommendations. We encourage people to take our patient versions and incorporate them into their own literature. And we encourage individual patients to look at the treatment that they're currently receiving against what we've recommended as good practice. And it's a way of being able to perhaps ask a clinician if a different treatment might be suitable for them. It may not be. Our guidance doesn't apply to 100% of patients, but it's an opportunity for them to look at what's been deemed best practice and compare it with what they're currently receiving. At the moment, and increasingly in the future, there will be a role for patients in using our guidance to help commission services and to monitor whether services are being delivered to a high quality. And there's a huge potential for the guidance that we produce as to be the basis of formal patient decision aids and formal shared decision making. And this is something that I feel that we're quite lagging behind a lot of other European countries in taking the evidence from our recommendations and converting it to something that's close to a formal decision aid. I've talked about this to a certain extent, so I won't dwell on it, because I'm very aware of time. But we, as an organisation, struggle sometimes with the public's perception of who we are as an organisation. They